treatments. Should have fixed some of the other slide portions that are still a little off, but empirical treatments are the big thing that I actually updated in some of these. All right. Now this slide deck is going to really be mostly about staph and strep infections. Okay. Simple stuff. This is what we're going to talk about: necrotizing fasciitis, strep. A lot of this stuff you kind of sort of know. So necrotizing fasciitis, aka flesh-eating disease. Okay. This can occur either through mono or polymicrobial reasons. This is one of the reasons why this is so rough. Okay? So either one thing can cause it or a whole bunch of things can cause it. We just don't know. All the things in this entire discussion for this PowerPoint presentation, you need to do culture and sensitivity. All of them. All of them. Just because, number one, you need to make sure what your microbe is. Number two, drugs to bugs. Drugs to bugs, right? And what that means is, depending upon what the bug that's causing the problem is, what you have to target the medication that you give. A lot of these disease processes are really, really bad. And when I mean bad, I mean they'll take chunks of skin off, or you could die of it. All right? So the sooner you can get medication on board, the better outcomes you will have for the patient. All right? So as we move through here, you may miss necrotizing fasciitis. I know I missed it probably a whole bunch of times. Okay? Necrotizing fasciitis starts off as a little pimple or red blotch. And when you look at it, you're going to think that it's probably just cellulitis. Okay? But what happens is that person's going to come back in a day or two because you just gave him some Keflex to take care of the cellulitis you thought he had or she had, and it wasn't that. It was necrotizing fasciitis. Right? You come back and you swab it because they're not getting better. The pain is out of proportion. Another thing that we'll talk about here in a second, you can highlight as a specific factor when we talk about necrotizing fasciitis. Rapidly progressing, pain out of proportion, pain in places where you would normally not think that they had pain. Okay. So how do you usually get it? Lacerations, abrasions, trauma, any of those things where you have breaks in the skin. There it tells you obviously everyone else who is most susceptible, obviously the immunocompromised, as we've talked about through this whole time period that we've been together. Anyone that has serious comorbidities, particularly diabetics, are more susceptible. And there at the bottom, it also talks about if you've had a tattoo or acupuncture or burns, or if you're an IV drug user, that makes you more susceptible to this. This thing starts innocuously and it progresses really fast. Right? Here's a whole bunch of things that can cause your problem. Right? There's a bunch of stuff that fit in the group A category. You got some aerobes and anaerobes. So there's a whole bunch of different things that can cause necrotizing fasciitis. Okay, so here's where you need to highlight some stuff. Rapidly spreading infection of the deep tissue. It's deep tissue because this is an anaerobe. It does not like oxygen. So it goes to the deeper tissues. It does not hang out superficially. Okay? It may cause some gangrene. That means that those portions of the skin or sub-Q that are affected aren't getting blood supply. If you don't get blood supply, it doesn't matter what you give them, because it's never going to make it to that area, right? So technically, what has to happen is you're going to have to cut that out. So surgery is an option for a lot of these folks. Okay, that very next line, you probably can highlight. Extension of skin looks like severe cellulitis, warm edema, eczema, but patient experiences pain out of proportion to the appearance. When you look at it, it may be a bigger red blotch or a larger bulla, right, or a larger pimple that's broken open than you saw initially. But when you start pushing on it and you start pushing away from the inoculated site, it still hurts, okay? Because it's going under the sub-Q fat. You just can't see it. All right, so those are all big giveaways to necrotizing fasciitis. And there it tells you it has moderate to severe systemic toxicity. If this thing becomes systemic, the dude's gonna be in a lot of trouble. If you push on it as it continues to get worse and worse, the skin itself may just go ahead and peel off, all right, because of all the gangrenous stuff under it. So those are big things that you can probably highlight, particularly that pain out of proportion. Huge distinguishing feature of necrotizing fasciitis. If it does become systemic, this person may have mental changes. So if you do think this is what it is, it tells you that high clinical index of suspicion. You'll see that on quite a few of these slides. Okay. Draw labs, do cultures, get your swab, and start them on medication immediately. All right. This progresses really fast. There it tells you it goes to deeper tissue. It goes to deeper tissue because of it does not like oxygen. Severe pain is proportional to the clinical findings. Right? Pain out of proportion. Failure to respond to antibiotics. Like I mentioned, I've seen some folks with, I thought where it was cellulitis. I gave them some Keflex. A day or two later, they come back and say, hey, this is not working, and the pain's really, really getting bad. That in itself should already tell you, okay, maybe it's not standard staph. Maybe we need to think of other possibilities, in which case necrotizing fasciitis becomes that other possibility. Okay, here it tells you may have a little woodsy feeling. Not necessarily a woodsy feeling as much as like a little bubble feeling when you push on it. Push on it, it almost feels like there's somebody blew some air under there, and you're just pushing a little bubble under it. Okay? And that's in about 60% of the cases, gas gangrene that's filling up under the skin surface. All right, that's really what you're pushing on. Okay. The tenderness extends beyond the urethema area, so that big red blotch you have, you go beyond it, it'll still hurt the patient. And you'll feel some crepitus when you push that little bubble feeling. You may have that bullous lesion, okay, that's the initial pimple that may be popped up. You may get a few more satellite lesions. And then you may notice some skin necrosis and echinosis. So I liken this to like an iceberg, right? Tip of the iceberg is all you see, but when you look underwater, which would be under the skin, it's freaking spread everywhere. Okay, that's what this really looks like, an iceberg. So what do? Patient sick. You don't wait for labs. Okay, patient sick. You don't wait for labs. We'll do that culture and sensitivity. You can draw blood. You can do whatever you want. Make sure you do all of that before you start empirical therapy. Okay? If you don't know what it is, you will start empirical therapy. Empirical therapy for necrotizing fasciitis is 3 different medications: vancomycin, piperacillin, tazobactam, and clindamycin. 3 different medications. Once you get that culture back, it'll tell you whether it's methyl-sensitive Staph aureus, methyl-resistant Staph aureus, at which case you can go ahead and tailor your medication for that. All right, so for MSSA, it'll be nafcillin or oxy and clindam. Okay? And MRSA, it'll be vanco or linezolid and clindam. Okay? Clinda gets added to a lot of these as we go through. You'll notice that because Clinda likes to attack some of the toxins that these things make. Everything that we're going to talk about within this little block here is because it's creating a toxin. Okay? It's creating a toxin in the body. That toxin in the body is destroying a bunch of stuff. Right? So these specific type of antibiotics are the ones that are going to help. There it tells you culture and sensitivity, treat the drugs, the bugs. And that culture and sensitivity comes back, it'll tell you a specific profile of what medication you really need to make this thing go away, to make the patient get better. Here, early open extensive debridement really helps with mortality. Right? We continue to let this go, this continues to spread all over. And the more it spreads, the more has to be removed. Okay? So the earlier the surgical intervention, the better. Right? Less gangrenous issues. And then there it tells you HBO. HBO is hyperbaric oxygen therapy. All right? HBO is hyperbaric oxygen therapy. Why do we do that? Everyone doesn't have hyperbaric chambers in their area. But the nice thing about that is that it increases oxygen delivery to tissues, right? It boosts the immune system. It boosts its function, right? It makes it stronger. It helps it fight, okay? It inhibits bacterial growth. Specifically with this one, because this one does not like oxygen. So if you flood it with oxygen, it's going to help make it go away a little bit faster. And then it also enhances tissue repair, the tissue repair process by flooding all your other cells with oxygen, so you're charging them up to help fight. Now, in some places, they may ask you, okay, why do you not think this is MRSA? Right? This criteria right here can kind of sort of gear you towards, look, this is probably MRSA, so you can start off with MRSA depending on how comfortable you feel. If you don't feel comfortable, just start off with the impaired therapy until you get your culture and sensitivity back. So these are specific MRSA risk factors. So if you picked it up, status post hospitalization or surgery, there's a higher likelihood of it being MRSA. MRSA initially, when we first discovered it, was really only found in hospitals as a nosocomial infection. And then it started becoming a big thing, and then we noticed it in the community. And so now we have a community-acquired MRSA as well. When I was in 10th Mountain, we had a MRSA outbreak. Everyone was going to the field, coming back all beat up. And we initially thought it was just a straight up cellulitis. We'd give people Keflex. They'd come back, pain out of proportion. Keflex did absolutely nothing for them. We'd swab it, send it off. They'd come back as MRSA. We had a huge outbreak. There was stuff that the hospital pushed out. It's like, hey, go ahead and start treating for MRSA if you think it's a cellulitis until we get this under control. So these things really look alike. That recent antibiotic use, right? That's the, hey, you think it's cellulitis, you give them something simple, and it doesn't work, and you come back with that pain out of proportion, or it just continues to grow and get worse. So look at some of the other folks that are really at risk, right? You have the incarcerated folks, you have homeless folks, and you have the IV drug users. Okay? Those populations are high risk for necrotizing fasciitis, right? More so because of the MRSA issue for them. If you have chronic wounds, so some people, you'll see that they always have like little open sores on their bodies. Some people are MRSA carriers. They just have it on their skin, and it doesn't necessarily make them sick, but when they do get wounds, the wounds last for long periods of time. Okay? Those are what we call MRSA carriers. For those people, usually we'll just prescribe them some Hibiclins. You have them wash from the neck down. Put it on from the neck down, leave it on for about a minute, and then wash it off. Do that for about 5 to 7 days. And usually it makes the MRSA on their skin go away. And then, depending upon where you are, is whether or not you do have MRSA outbreaks or not. Right? As I mentioned, when I first arrived at 10th Mountain, there was no MRSA outbreak. Okay? People were coming in, standard cellulitis, we take care of it. Hospital called it because we were having a lot of people come in with MRSA positive infections. So they called it MRSA outbreak. Okay, so if you do have, or are going to work in an area that has that, you know, you're more towards what's the most common in the area that you're working in. Okay? If it's yes to any of these, then you could probably think it's MRSA. If it's no, maybe it's methyl-sensitive Staph aureus. Okay? These are not definitive, but it'll give you a point of reference to think about, okay, maybe it is versus it isn't. Okay. X-rays may show bubbles, approximately 60%, but the bubbles are not definitive. Okay? The bubbles don't mean that you have necrotizing fasciitis. So that may show, but it's not something that you can definitively count on and say, oh yeah, it's necrotizing fasciitis because you have bubbles. Okay? You can have bubbles for quite a few other things. Now, because this is soft tissue, you can do a CT or MRI to see if there's any other body cavities that are being affected by the necrotizing fasciitis, if you really need to figure out if there's any other place that's being affected in the body that you have to investigate. But surgery is what you're going to need to do, okay? So if you take a look at this guy, you can see this big giant bruise he has here on his back, right? And then up here, it's already ripped. Okay? So the question really lies for someone who doesn't know the history here. Did that rip open? Okay? Because he's got the infection, or they cut him open to alleviate some of the pressure and pain that he already had. And they just tacked it closed so that he wouldn't get any further infection. All right? So this is before surgery. This is after surgery. Okay? This thing went on so long that they had to remove, this is almost his entire back, right? And this goes on, it's under the surgical drape here, this goes on to his upper right shoulder and the posterior aspect of his right arm, okay? So, drugs to bugs, surgery for any gangrenous tissue so that it can actually let the healthy tissue survive and continue to grow, and you can get better penetration with the antibiotics once you get to it. All right. Questions? Yes, no, maybe. Strep throat. Who has not had strep throat here? Everybody's had strep throat? Great. Okay. Maybe. Yeah, but because you're back, right? Because you're back. Great, because you're back. Great, because then you should really know what some of those signs and symptoms are. This is caused by group A, beta hemolytic streptococcus. Okay, so it's the strep. Right, there's your peak seasons, late fall to early spring. Mostly children, not as much as adults. Your age groups can be between 5 to 12. Right? Not usually seen in children under 3. But transmission is generally direct person-to-person contact or respiratory droplets out and about. Here it tells you crowded areas, so any respiratory issue in a crowded area is gained. Right? Because you cough, talk, spit, yell, sing in a crowded area, it's going to be out there, and other people are going to inhale what you just put out. Okay? So respiratory issues, crowded areas, usually not good. All right. Here's all your signs and symptoms. Tonsils typically enlarged, red, pop, plus or minus exudate, dysphagia, anaphasia, fever, chills, malaise. Okay. So now that you have those, who remembers the center criteria from AT&T? That was ages ago. That was a long time ago. I don't remember what happened yesterday. Yeah. All right, so let's just go over this real quick. Exudate, right? Exudate, tonsillar swelling, anterior cervical adenopathy swelling, right? Fever greater than 104, okay, that denotes your fever, okay? And cough, yes or no. So out of those 4, how many do you need to have to just go ahead and pre-treat? At least 3, correct. Right? So it needs at least 3, you can just go ahead and pre-treat. Right? Now, what do we generally do in the clinic? During the clinic, we just tell the nurse, hey, do a rapid strip on them, have them sit outside, you wait 15 to 30 minutes, the lab sends you the results back, yes or no, and then you can treat or not treat. Okay? That's reality. So rapid strep is something that you can do. You can swab it and send it off for a culture. You do that. Okay. But these are your signs and symptoms. Use center criteria. You need at least 3 at the minimum of the 4 in order for it to be positive, or you can just go ahead and pre-treat. Okay. This one I'm not quite sure, because if you look at this is your anterior pillar, right? Guys remember what that is? Your little dangly thing hangs down from right? The uvula. Your tonsils usually sit right back here, not in the anterior aspect of this. So, not quite sure. This almost looks like cauterization surgery. The diagnosis, usually clinical presentation, right? We don't have to do a culture, we don't have to really do anything. If they have stuff, then we just clinically diagnose and treat, all right? What do we treat with? I'll give you a couple here because there's a lot of choices. But for those that are not compliant, right, really the little babies, right, because we're gonna help the parents instead of having to give them pills every single day for the next 10 days, right, which would be the Pen-G or the amoxicillin. We can just give them a shot of Pen-G. It should be good, right? Or you have that 20-year-old where you tell them, hey, take this pill for the next 10 days. They may or may not be compliant. You don't know. So, easiest thing to do is the shot, from my standpoint. I like to give you alternatives for penicillin allergy. Here I put clindamycin. I probably should have changed it and just made it azithromycin. I didn't want to do that, or erythromycin. I didn't really want to use azithromycin with this because with this, they've been noticing some resistance against azithromycin. So I didn't want to put azithromycin here as your alternative because I think as we continue to move forward with medicine, more and more resistance is going to start showing up to some of the alternatives that we use. So any of the SINs you can use here, you can use erythromycin if you want. Clindamycin is fine. But this is really based on where you work. So where you're working, there's a high resistance against azithromycin, and I would suggest not using it. Okay? But you'd have to figure that out once you get to wherever you go. Now, here's the deal with the strep throat and the treatment. Do I need to treat? Yes or no?
Yes.
Yeah, I do. Right? Because that could lead us to rheumatic fever. Right? That could be one of those complications of not treating strep appropriately. Right? Now, these are a whole bunch of complications, and then here's some differentials, but rheumatic fever is just a complication of not treating strep appropriately. All right? So make sure you treat it appropriately. What are some of the sequelae for rheumatic fever? That's the other reason why we want to make sure we definitely treat. So if you look at the bottom there, okay, it may lead to progressive valve deformity years later. So if you look at the mitral valve, 75 to 80%. If you do end up getting this and it's not treated appropriately, it may affect your mitral valve. All right? So that's one of the reasons why we definitely need to treat this thing. It generally occurs 2 to 3 weeks after infection. Okay? Rheumatic fever usually may occur if you don't treat it appropriately 2 to 3 weeks after a streptococcal infection. Okay? Your peak incidence 5 to 15 years. Okay? So, have you guys seen rheumatic fever before? In any of your classes? Okay. So what's this criteria called? What is it? Jones, correct. This is what we call the Jones criteria. Jones criteria is what we use to figure out whether a person does or does not have fever, rheumatic fever. A lot of times this is just diagnosed clinically. You don't have to do a whole bunch of stuff. Okay, it's clinical diagnosis. Okay. So here's presence of 2 major or 1 major and 2 minor criteria. Okay, that establishes diagnosis. Here are your major criteria right here. So this right here, you can see this right here. Okay? This is one line, this is another line. So these are in the middle, not in. Right? So it would be carditis, erythema marginatum, subcutaneous nodules, synovial or polyarthritis. So you have 5 major criteria. If you have any of those 2, okay. Diagnosis is made for rheumatic fever. If you don't meet any of these 5, right, then you could look at, okay, 2 minor and 1 major. And here are your minors. Okay. Fever, polyarthralgias, prolongation of PR interval. I don't know why this keeps going back. This should be the first line here. So elevated sedimentation rate, ESR. Okay. ESR or CRP, either or, because either of them are really looking for inflammatory process. All right. Now, this one does have a caveat, right? You guys remember what that caveat is? No? Okay. So if you go back here, right, this is the heart, right, carditis. Polyarthritis is musculoskeletal. So if you come back over here, this is the heart, this is musculoskeletal. Okay. So you can't use them both together. Right? So if I have carditis, I can't use a prolongation of PR interval. I have to use one of the other 1, 2, 3 of the other minor criteria. Okay. If I have polyarthralgia, I can't use polyarthritis. Got to be something other than the system that you're talking about. That is the only caveat that we have when we're looking at whether or not they fit the Jones criteria. So 2 major or 1 major and 2 minor. Right. Clear as mud? Yes, sir.
What's the erythema marginatum?
Erythema marginatum is a big rash, big red rash on your skin someplace. And then your other one, your subcutaneous nodules. That's just subcutaneous nodules are just painless, firm nodules that pop up in different parts of your body. Could be over your shins, could be over your forearms, could be in your flexor areas. Any other questions? Yes, no? So what are we going to do to treat? Pretty much nothing. Right? So here's the key to this. The guidelines still recommend high dose aspirin as a means of treatment. But remember your age ranges 5 to 15. Right? You have to be careful with rise syndrome if you give kids aspirin. So because this is an inflammatory process, which is why they say, hey, give high levels of salicylates. Right? You can also try anti-inflammatories. All right? So naproxen and Motrin at high enough levels will be anti-inflammatory as well. So you can use anti-inflammatories if you're concerned about giving kids aspirin. Your choice. All right? But the guidelines still say high dose salicylates are still optional. Then what are you going to do? You're going to give them Penji, same thing that you gave for strep, right? Nothing different. And or Penvi orally times 10 days. Okay? And here I gave you your penicillin, allergy will be with azithromycin. Right? Now, if it's really, really severe, then you can also, on top of that, add steroids. Right? Because remember, this is a wholeheartedly an inflammatory process, and steroids would knock it down. So remember, steroids have side effects too. So we don't necessarily want to use them if we don't need to. All right, scarlet fever, group A beta hemolytic strep. Everything that we're talking about today in this block is caused by some sort of toxin. Okay? In this case, it is the urethrinogenic toxin. All right? That's what's causing all these problems, is a toxin. All right? So high grade greater than 101. Key here, the fever starts before the rash does. In some cases, the rash starts before the fever, but in this case, the fever starts before the rash. And have some chills, headaches, nausea, vomiting. I would probably highlight the bottom two. The tongue dorsum with white exudate. So the top portion of your tongue is going to turn white. All right? And that's usually on the early phase. And then later on, later phase, 4 to 5 days in, it may become edematous papule with strawberry tongues, what we call it, because all your papules are going to be enlarged, and it's going to look like an outside portion of a strawberry. So here, people usually breathe in the stuff with the bacteria, or they touch something that's been infected with the bacteria, and then they touch their mouth or their face, or they drink after someone who has had this, and then they spread it to themselves, or direct contact tracing, spread it to each other as well. So this is a huge one that you should probably highlight. Fine papular or punctated lesions, texture of coarse sandpaper. As time goes on, it'll desquamate, and usually that happens after the fever breaks. Desquamation is just a fancy word of saying that the skin peels off. The skin just peels off, and it kind of looks like a sunburn as the skin's peeling off. That's all that means. And that's after that coarse sandpaper rash that you'll have. Look at where it starts. Axilla, groin, and neck. Axilla, groin, and neck is usually where this thing starts. The other ones that we've talked about have been like outer arm, face, and work their way down. This one's axilla, groin, and neck. So, scarlet fever, because your face turns red. Your face turns red. Whole face. Okay? And another one that we're going to talk about, where it's just your cheeks turn red. This one, your whole face turns red with that circumoral pallor. That means the area right around your mouth stays the same color. Everything else turns red. Forehead, cheeks, everything else. Okay? So that is a quick way to look at someone and say, oh man, yeah, you probably got some scarlet fever going on. Right? It's very, very distinctive. How do you treat it? Pen B, penicillin algae, azithromycin. If you really want to, you can grow culture, but generally we don't really do that stuff. It's just diagnosis, clinical diagnosis. As we've been moving forward, and we've been noticing that there have been some outbreaks of this, particularly here in the U.S. and over in Europe. Okay, so it's going to be something that may start popping up more frequently. This really isn't something that we generally see all the time. So here's the white exudate on the tongue. Okay, here's the desquamation of the skin. So it really does look like a sunburn peel. Right? And here's your strawberry tongue. You can see that because it's red on red, but all these little things are just raised papules, inflamed papules on the tongue. They're natural, they're normal for you, they're just enlarged. And your whole tongue is red. You just have to be careful with using this as something that really denotes it, because it does not. Alright, there's a couple of other things that also have strawberry tongue. It's not just scarlet fever. Right? Kawasaki's disease is one that comes to the top of mind, where people will have a strawberry tongue appearance as well. So, not necessarily pathognomonic. Alright. Staphylococcal scalded skin syndrome. This one's called Ritter's disease, also known as Ritter's disease. Right? Dr. Theodore Ritter discovered this back in the late 19th century. Those things have been around that we know of. Okay, it's very similar to scarlet fever, but the toxin in this one is called an acute exfoliation toxin. And this one turns your skin red, and you may have like little blisters on your skin. Now, what really denotes the huge difference with this one and some of the other ones is when you touch that skin, not only does it hurt, but the skin itself, the top layer will just peel right off. Okay? So just imagine a burn where the top layer of your skin is burned off, and you can see the underlying portion of your skin. That's what happens with this one. Alright? So I say it's very similar to scarlet fever because you're really going to turn red. In certain areas, not your whole body. right? The toxin itself is what's going to cause that. And the most common sites are oral, nasal, throat, and umbilicus. Okay? Umbilicus because it happens to babies. It happens to babies. When it does happen to babies, it usually affects them at the very beginning of life. Right? Sometimes, if things are not sterile, right, that non-sterile scissor that they use to cut the umbilicus may spread. Right? That's why we like to use sterile equipment when we do a lot of surgical procedures, so we don't spread this stuff. Okay, so what do you have? Fever, tenderness, palpation, warmth, right, because it is an infection. Okay, diffuse erythematous rash, sandpaper bull-like, looks very similar to scarlet fever. But I highlight Nikolsky sign. And what that is that slight gentle stroke of that area that looks affected, it just comes right off. Right? Separates that of the nerves. And that's really, really bad, especially in neonates and infants. Okay? When you hit that, you have to think about dehydration, right? Because they don't have that compensatory measure. And then the other thing that you have to think about is that almost looks like a burn, which means you have to be very aggressive with these little kids. And if you have a burn unit, a lot of times they usually put these kids in burn units and treat them that way, because there's a lot of different things that you have to concern yourself about, not just necessarily secondary infections. Right? You got to worry about your electrolytes. You got to worry about temperature regulation. Once that top layer of skin is gone, you have to worry about dehydration, especially in babies. So there's a lot of other things that you need to be concerned about with little infants. So if you can put them into a burn unit, let's put them into a burn unit. This is what it looks like. Okay. Whole top layer is just gone. It looks red. It almost looks like a burn. Right? Most common areas, right? We talked about, right, around the umbilical area, diaper area. Those parts you can really see it, particularly around the umbilical stump. Here's another one. Right? Around the diaper area. This young lady has it on her face. Right, so how do we treat it? Supportive care is key. Supportive care is key, especially because most of these are young children and they don't have the compensatory measures, so you gotta make sure they stay hydrated. Right? Culture and sensitivity is key because that'll direct you drugs to bugs. Right? Make sure you do your swabs and send them off. Culture sensitivity. Okay. So here, your impaired treatment will be Nafcillin or Oxy and Vanco or Clinger. It'll be 2 meds for your impaired treatment. Once you get that culture and sensitivity, then you can narrow down if it's MSSA or MRSA. And then you can pick one of either for treatment. Just remember, this thing kind of sort of looks like burns for these little kids. So there's a lot of things that go behind that supportive treatment, which include electrolyte balance, temperature regulation for them. Keep an eye on them, make sure they don't get secondary infections, because we don't want them to become septic. Usually these kids really resolve pretty well with minimal issues. Toxic shock syndrome. This is usually associated with women who use tampons for longer periods of time. Right. This is caused by Staph aureus. Okay. There was an outbreak there between 2017, 525 cases. So in England and Japan, instead of using TSS or toxic shock syndrome, they use TTS, toxic thoracic syndrome. So they have a slightly different name for it, but it's the same exact thing. Okay, first described in children in 1978. But this is most commonly caused by Staph aureus, especially when we talk about tampon use. It can also be caused by strep pyogenes, but it's a lot more rare that it's caused by strep pyogenes. Right? More common than Staph aureus. And it's a sudden onset of severe symptoms that can lead to shock and organ failure, multiple organ failure. So you gotta figure out that these people have this, and they gotta go into the hospital. These people have to be in the hospital immediately. Right? The specific toxin that causes this one is TSST1. Okay. So here you're going to initially have influenza-like syndrome, fever. Confusion usually starts happening once it becomes systemic. Once it becomes systemic, the TSST1 toxin is going to be everywhere, and it's starting to destroy a lot of things. It's going to make it to multiple organ sites, and it will continue to cause the body's immune system to blow up. Right? The body is seeing all this toxin everywhere, and the body's immune system is just trying to figure out what's going on, and it causes that over-inflammatory process. Remember those cytokines that we talked about a long time ago? Those cytokines are off the chain. Those things are blowing up. They're trying to stop everything, and they can't. So because they can't, they're calling more. And when they call more, hyperinflammatory process occurs everywhere. Okay? So your body just can't handle it. So if you look at these feet, desquamation is something that happens with the rash, both the palms and soles of feet. So here you look at the presenting complaints: pain, vomiting, nausea, diarrhea, influenza-like symptoms, headache, dyspnea. So pain and vomiting are the two largest ones that you may see when they present with toxic shock syndrome. HPI is extremely important for this, especially if you're thinking that it is a tampon-related issue. Okay, so you can get some bully on the skin. There's little larger blisters that occur. Okay, you can get a scarlet fever-like rash as well with the little bully on there that almost looks like skin scarlet syndrome. Okay. You'll get some desquamation. That's the peeling that we saw on the feet. Okay, and it does not spare. It does not spare, so it involves your palms and your soles. Remember the last block we said, hey, one way to differentiate things is if it involves your palm and your soles. In this case, it does. Right? Hypotension is key. If you see this, if you see hypotension, you really need to think of toxic shock syndrome, especially if you're thinking of Staph aureus infection. All right? Because you have that giant inflammatory process going on in your body, and that toxin is still being released, it can also affect your heart and your vessels. Right? The inflammatory process is blowing up all your vessels and causing them to inflame. As they inflame, they cause capillary leakage. As your heart inflames, you end up with carditis. Your heart doesn't work as well and doesn't pump as well. Okay? So you've got vascular leakage, you've got your heart not working right, so that's going to cause hypotension in this case. Right? Here it just says systolic less than 90. Okay, both systolic and diastolic are going to drop. They're going to be really, really low. Okay? So hypotension is a key for this as well. So if you see any of these, you should probably think of toxic shock syndrome, sudden onset of fever, rash, hypotension, and systemic evidence of toxicity. All right. Women, most common. Right? Usually it's that's post having the tampon in for long periods of time, using pessaries, using cervical caps, using menstrual cups. So any device that could harbor a staph that they leave in their vaginal canal for long periods of time can lead to this. It's not just tampon use. All right? That's why asking those HPI questions about what they're doing is extremely important to kind of figure out what's going on here. All right? This thing can be caused by three different things, right? You've got MSSA, MRSA, or strep. Strep, not as common, but you still have to differentiate MSSA versus MRSA in this. Because those are the more common ones for toxic shock syndrome staff. This is supposed to be a diffuse rash. Okay. This is desquamation. And this is breaking up that skin is starting to come off. All right, so here's some criteria for you to see if there is multiple involvement or multiple organ involvement within toxic shock syndrome. All right. So, three or more of the following to tell you you have probably toxic shock syndrome, and these are the specific organs that are involved. Okay. So they're vomiting, diarrhea, will be your gastrointestinal. Okay, your musculoskeletal, you'll have increase in your CK. Okay, mucous membranes, vaginal, oral, any mucous membrane, right, that's inflamed or irritated. You can do lab for your renal function, lab for your hepatic function. Okay. Hematologic issues, right, thrombocytopenia, especially if it's inflammation's going out of proportion, you're starting to leak stuff out. So if you look at any of those, three or more, we should tell there's multi-system involvement with toxic shock syndrome. Okay, so what are we going to do? We can do culture sensitivity. Whatever you can culture, whatever you can draw. If you're not quite sure, send off for culture sensitivity, and then aggressive supportive therapy, because this thing is going to affect your heart and your respiratory tract. So aggressive supportive therapy, and then empirical therapy, and that one will be vancomycin, clindamycin, and piperacillin tazobactam. So using 3 for empiric. Once you get that culture sensitivity back, then you can back down and you can figure out if it's MSSA, then you could give napsilin and clinda, MRSA, vanco and clinda, and if it's strep, then PNG and clinda. That way for that culture sensitivity to come back to be able to specifically say, hey, this is what I'm going to use. All right. And just be aware of the tampon use for females. If they do have it, and they do get toxic shock syndrome, your recommendation should be that they do not continue to use tampons. So I'm going to use pads instead. Once you're susceptible for toxic shock syndrome, your likelihood of getting it again, if you continue to do the same things that you were doing before, may make you more susceptible to getting it again. Okay. If they do want to use pessaries or anything like that, hey, tell them that you can use them, but as soon as you're done, you got to take it out. Okay. And what happens is it changes that pH and that balance inside the canal, which allows some of the bad stuff to overgrow if it's left in for longer periods of time. That's what we don't want, because that may, again, lead to toxic shock syndrome. And these people need to be put in the hospital. If you really need to and you're not quite sure what's being affected, right? This is a whole body inflammatory problem. You're going to do CT, MRI, and you can see inside to see what soft tissues or organs are actually being involved. Okay? That's another thing that you could possibly do if you really need to. Here's some complications of sequela. Hypovolemic shock's a big one. All right, let's go ahead and take a break. Okay, this one is caused by streptococcus. Somebody pronounce that for me. Yeah, there you go. So there's your main cause right there. This can cause sepsis, meningitis, particularly in neonates. This first section, right here, the next 2 or 3 slides, we're really gonna focus more on pregnancy and the neonate. This does happen to adults, not too big of an issue, we give some meds that get all better, but in the neonate and in pregnancy, it becomes an extremely important thing that you need to, that you need to cover. So here it says causes prepartum fever in women. So if a woman that is pregnant gets a fever, one of the first things you need to think about is group B strep. Okay? And then you can test her for it. You can just have her do a urinalysis and or blood, and it'll tell you whether they have it. They should be treated for it. The key to this is that at a minimum of 4 hours before delivery, they still need to get treated. This prevents at least 90% of infection being transferred over to the baby via vaginal or natural birth. Okay? So if you have group B strep as a pregnant person, you will be a group B strep person forever. So whenever you go to deliver, they will hang a bag of meds for you at the minimum of 4 hours prior to delivery. Okay. Okay, there it tells you it accounts for some infections in non-pregnant adults, serious infections. Okay. So there's really two types of the neonate that we're really going to talk about. Is the early one. The early one is less than 6 to 7 days. Okay, it's as soon as it's born. Or the late phase, which is greater than 7 days up to a year, I believe. Okay, so early onset from that first week usually starts about 20 hours after. Okay, 50% signs of disease at birth. Okay, so they already have some signs. Usually becomes more apparent within the 24 to 48 hours after birth. Okay, and what happens is as the baby is born, it picks it up from the mom through the vaginal canal, and that's how it gets it. This thing can lead to sepsis, pneumonia, more so meningitis in the infant. Alright. Here's some complications: fever and prolonged labor, prematurity. This one's similar to the other neonatal sepsis, respiratory distress, lethargy, hypertension. If you don't adjust these pretty quick, you could possibly die. Right? This thing progresses very fast once they get infected. Right? Sepsis, meningitis being some of the bigger things that the baby needs to be careful with. Then after this, you have 1/3 or greater end up getting pneumonia. They can end up with respiratory distress. 1/3 if they have meningitis will have fever, lethargy, irritability. So these are more symptoms that the baby can have that they will be looking for. Okay. Late onset, usually a week to about 90 days. 3 months, 2 to 3 months, 90 days. Okay, with a mean average of 3 to 4 weeks. Usually this babies are a little bit stronger already. This one is kind of questionable whether they did or did not get it from mom, because they've gone for such a longer period without demonstrating some signs and symptoms. So here it also tells you if it doesn't occur at birth there, it could be a later colonizer, which means they did get it, it's just going to colonize, take a little while before it actually kicks in from mom. Or you can get it from the nursery personnel that's taking care of the baby, which is one of the reasons why they're supposed to gown up when you're taking care of the baby, so that you don't spread anything else to them. You wear your little mask. Or in some cases, we don't even know why or how the baby got infected for the later onset. And there it tells you can show bacteremia, osteomyelitis, enterocolitis, social swelling. Right? So some babies still get group B even if they get tested. Even if mom gets antibiotic therapy during or before delivery. Okay, here's a whole bunch of things you can do, cultural sensitivities, procedure analysis. Okay. The treatment, early onset will be ampicillin, gentamicin, late onset, and or for adults as well. You can do Pen-G or ceftriaxone. Okay. Now, as I mentioned before, if a mom does have positive group B strep in her urine, she needs to be treated regardless of what stage of pregnancy she's in. Okay. I believe the CDC says around 37 weeks or so, you should check pregnant women for group B strep. When you start doing well woman exams, they'll give you a list of, during each trimester, what you're supposed to test for. Okay. This is going to be one of those things that you're actually going to test for. But even if you do treat the mom, pregnant mom, at the minimum, 4 hours before they deliver, you will still hang antibiotics prior to delivery. The main reason is, if there's any residual group B strep left in the vaginal canal at the minimum 4 hours, starting off that antibiotic, it'll get rid of the group B strep. Usually helps about 90% of the time. Nothing is 100%. So you still have a 10% chance that that baby may have it if mom still has it. Okay. Here's some complications. Mortality is 10 to 40%. Okay. Big deal for the ones that end up getting meningitis. 25% of them end up having serious complications. And there's some other complications on there, which is one of the reasons why, hey, if we can prevent it, that's really what we want. Prevention is key. But if we can't, we want to try to figure it out earlier than later so that we can address it. Hopefully it doesn't become septic or lead to meningitis. Because we don't want them to have these complications. Status quo, they're survivability. So majority related to pregnancy and fertilization, okay, pregnancy and delivery. Other folks that can get this will be elderly, folks that have chronic underlying illnesses. Okay. Their case fatality rate exceeds 40% because they already have problems, and now you get another problem on top of the problem they already have. And then in some cases, depending upon what the problem is, i.e. the immunocompromised issue, you won't know that they have it till later on in the infection, which means it's already done a lot of damage before you can actually give them some antibiotics and make it better. Here's a bunch of consideration to think about, right? Pericardial fever. So if a pregnant woman has got a fever either before, during, or after pregnancy, one of the things you need to think about is group B strep. Okay, if someone has urinary tract infections commonly, one of the things you should think about is group B strep. And some of the other things that group B strep can cause would be the pneumonia, endocarditis, septic arthritis. So there's a whole bunch of other little issues that this thing can cause. Okay, we can do blood culture, CBC urinalysis, CSF, especially if we're thinking meningitis type issues. And then treatment is Pen-G. Pen-G. MRSA. Okay. Infection is similar to Staph aureus because that's what it is. The only difference is that it's resistant to bacillus. It's the only big difference. Can affect skin, joints, causes pneumonia. Okay, it's typically acquired in institutions, right? When we first found this stuff, as we mentioned a little earlier, we would only see MRSA type stuff in hospital settings. Nowadays, it can be acquired in the community in some places. Some places they have outbreaks. Don't discount MRSA, particularly for the IV drug users. Okay, high-risk settings, incarceration or prisons, competitive sports, and those military training environments. That's where you guys are going to be. So don't discount discount MRSA when you see little bumps that appear, redness of the skin that continue to grow, and your standard medication doesn't do anything for them. Right? It could appear like a little bump, it'll be red, it'll be swollen, it'll be warm to the touch, may or may not be full of pus. Right? But it's usually accompanied with fever. We do have some folks that are MRSA colonizers. Right? Real quick way to note, because most people don't know. Right? I can't say you have MRSA versus you don't have MRSA. I can't just look at someone and say that. Now, for those folks that do have little breaks in their skin, right? And they're common there, and they're always there, or they happen and they stay for long periods of time to have little pops that are open. Okay? And they tell you, oh yeah, I get them all the time, and they just don't ever go away. Or it does, it takes just a long time for them to go away. Generally, those people are MRSA carriers. They're asymptomatic, right? They're asymptomatic, but the non-healing sores are kind of sort of a possibility that it may be MRSA. In which case, you can always swab them, send it off to the lab if you like. It's not causing them any issues. There's no big rush. Or you can swab a couple of them, send them off, and then give them some Hibiclens, and tell them to wash from the neck down. Leave it on for about a minute or so, and then wash it off for the next 5 to 7 days. Maybe that'll help. Okay, for those colonizer patients. And if you look at some of the more leading states that have MRSA, okay, you got Alaska, California, Georgia, Texas. That 60% ebbs and flows, fluctuates, and it depends upon the state and what's reported as well. Okay. This is what we call a heat map. All right. What's nice about this, I never tell you, this is an antimicrobial resistant in animals in low and middle income countries. Right, so everywhere you see the white, red blotches there, there's antimicrobial resistance. And this public health group is from Germany. It's not here, but it covers stuff internationally. And this is what allows us to know what kind of meds we need to treat for what kind of disease processes are in different parts of the world. MRSA, how do we get that from animals? Well, the stuff usually lives in your guts and intestinal tracts. We try to give them antibiotics to try to keep them healthy and allow them to grow big and strong. Inside their gut, sometimes the stuff does not get killed and it creates resistance. And as they go through the processing plants and they come to us, if the stuff does not get killed in the interim, then we're ingesting it. Which is spreading that already resistant bug to us. Okay, in this case, we're talking antibiotic, MRSA, but we can be talking about quite a few other things that we get from animals. Okay, so MRSA treatment, management, outpatient. Magic number is usually less than 5 centimeters for treating people outpatient. They have a single abscess, less than 5 millimeters, not a problem. Or you can have a couple, it depends on what your thought process is when you're looking at those patients, but centimeters should be less than 5. You can give them oral antibiotics, trimethoprim, sulfamethasone, Doxy, Clinda, will all work against MRSA. Right? And there it already tells you Clinda, you have resistance in some places. But if you're going to put them in the hospital, you can use vancomycin. I'm not giving you a whole bunch of different things in here. You can use lisinizide there as well. Problem with lisinizide, it's not everywhere, doesn't have it, and it's really expensive. But it does a really, really good job at covering stuff, as does vancomycin, and it's cheaper. Okay. Remember, the drugs for bugs, you need to go ahead and culture, right? And give them some stuff. cultural sensitivity comes back and it matches, great, perfect, you can stay on it. If it does not, then you need to change your planning strategy to what's actually gonna kill it. And that's gonna really be dependent on the geographic location. As that heat map showed you, there's different parts of the world that have elevation of resistance against certain antibiotics. Okay. So remember, key is drugs and bugs for all of these. Okay. Why do you think muscle colonization is common in physicians? Why? Everybody wears freaking gloves, man. Start touching people, they don't know what they got. That's what we tell you. Hey, just wear some gloves. Protect yourself. Protect yourself. Wash your hands. Okay? You gotta be careful with spreading it. And here it tells you freaking hand washing gels, alcohol gels, properly handling bodily fluids. Don't do it without the glove on. Okay? Keep your fingernails clean. Keep your fingernails short. Nothing can get under them. Right? Right, for those back-to-back carriers that we talked about earlier, there's your hibiclens, but a lot of times the most common place where you carry it is inside their nostrils. So you can also give them some Bactroban or Nupercin and have them put it in their nostrils. That'll kind of kill it. Things to tell folks, hey, don't share towels, don't share washcloths, don't share razors, and don't share clothing. Folks that have it can spread it to other folks, especially if you have breaks in the skin. Tetanus. Okay, this one is bad. This is Clostridium tetani. This one produces a toxin called tetanospasm. Okay, and what that tetanospasm toxin does is it cuts the brakes from your neurologic system. Okay, right? You guys remember GABA and glycerine? Remember that from neuro? Okay, that's what gets shut off when we want to stop stuff. Okay, so tetanospasm blocks that. So if we block something that's supposed to help us stop our muscles from going, your muscles are going to continue to go and go and go and go. Right? That's why these guys usually get lockjaw or spasms or seizures, because their muscles are not stopping. They're still being triggered. Okay? That's what that tetanospasm does. How do you get it? Usually from some opening on the wounds of your hand, your feet, and you touch something contaminated. With Clostridium tetani, and that's how you get it. All right. Two forms, right? Two forms, just like you guys remember blasto and histo. Same deal with this guy. Lives in two forms, right? He has the spore form, which is the dormant stage or the resistant stage when it lives outside your body. That's how it survives. And then once it gets into your body, by some cut or something on your leg or foot, and then as it warms up a little bit, it goes into its vegetative state. Once that vegetative state kicks in, that's when it starts creating that toxin. And that specific toxin for this one is that tetanospasm. Right. Same deal with this guy. This guy doesn't like oxygen, so we'll try to go deep. Okay. We don't usually get this here in the U.S. much because most of us are vaccinated. Okay. This is one of those musts when you're a little kid, you get it. All right. Stuff usually lasts about 10 years. Okay. But here it talks about a couple of other places where this has happened, that cost burden of $1 million for being hospitalized because of tetanus. Right? This is another aspect of medicine, is that cost burden. Okay? And usually we'll see this overseas because they don't usually have tetanus vaccines. Okay. So this thing can show in 4 different ways. Your general tetanus is your most common. Okay? That is the most common. Go down, get something, gets into your skin, you end up with lockjaw, right? Muscle spasms, seizures. That's about 80% of the cases right off the bat. Generalized tetanus. That's all your skeletal muscle. Then you have localized tetanus. Localized tetanus is usually wherever you get inoculated. Okay, it usually kind of stays in that little confined area for a while. Okay, and it just irritates and causes spasming in just that area, just whatever localized area it is. Okay, the problem with that is that if you continuously let it go and you don't address it, it has the propensity to become generalized. Right? If you take care of it early, it'll just stay localized, not issue, not a problem. But if you let it go, it can become generalized and it'll spread to your whole body. Right? A lot of times folks that are partially immune, or us that are getting closer to that 10-year or have just gone past that 10-year time period with our vaccines, may have localized tetanus. Then you have your cephalic tetanus. Okay? That, as it says, cephalic, right? Okay? This one only affects your facial muscles. Biggest difference with this one is that it causes your face to just completely droop. Your whole face just kind of droops. Okay? That's what it does. Just like localized, cephalic tetanus can also spread systematically or systemically to the rest of your body if you leave it go. Okay? So you want to try to address that as fast as you can so it doesn't. And then ultimately, you have neonatal tetanus, which is very similar to generalized tetanus. It just happens in babies. A lot of times, what spurs this on is using a non-sterile scissor to cut the umbilical cords of babies, and that's how they end up getting the tetanus spore for neonates. So we should use sterilized equipment all the time. This stuff usually in babies kicks in usually in the first week or two of birth, if we're using something that's not sterile or contaminated. Okay. So here's some signs: trismus or lockjaw, most common signs you can have. Okay. Irritability, cramps, dysphagia, associated fractures and dislocations, because your muscles are going to be so tight, you're pulling on your bones and your joints. Because they're pulling on your bones and joints so hard without having anything to make them stop. In some cases they cause fractures. Right? More so in babies, because their bones aren't as strong as ours. Right? Their bones are still growing, so you'll see that more common in babies than in adults. It even causes dislocations, and in adults usually it's more of a dislocation than a fracture. These guys need to be hospitalized, because as this continues to go, it will affect your respiratory system. These guys need to be hospitalized. This thing can go and involve your central nervous system, causing meningitis. Okay. The thing with these particular ones that do tend to affect your central nervous system, the closer to the central nervous system that your inoculation site is, the faster you'll have central nervous system signs and symptoms. Right. This one does retrogeal neurologic progression. So once it gets into your nervous system, It starts going backwards towards your brain. Okay. It's one of the ways it likes to get into your central nervous system. Right? So here's a whole bunch of things that can happen: frequency and severity of seizures. There's a whole bunch of different seizures that you have there. The problem with this case versus an actual seizure patient is that this person feels everything that's going on. They don't have that lucency that a standard seizure patient will have. This person is awake and feeling everything that's going on in your body. So do not forget to give this person a muscle relaxer of some sort. Valium is a really good one to use. Okay? This person ends up having seizures or serious lockjaw, and give them some sort of muscle relaxer. Other things that can occur there is your pythosnos. Really what that is your whole back just curves backwards, your head goes back, your legs go back. I'll show you a picture of that. That flexion, abduction of the arms, right here, clenching out, clenching in of your hands when all your muscles get tightened up. So these are a whole bunch of different postures that you'll have from folks that are actually having muscle contractions. This little baby has some lockjaw going on right there. Okay. He's got the clenching fist up to his chest. This is what pythosnos looks like. It's literally like his head is yanked back. He's got that curvature of his back, and his legs are kicked back. So he's in a backwards march. If you could do that with a regular baby, this baby has a full body span. So when we talk about this, when we talk about these guys having some issues, make sure you address the musculoskeletal problems as well. Okay, muscle relaxers. Tetanus is usually a clinical syndrome. Okay. HPI is really what's going to tell you what happened. Okay. HPI and the physical is going to tell you what happened. Tons of confirmatory laboratory tests that we do for this thing. We're really not going to find too much. If you do think it is neurologic, then go ahead and do a lumbar puncture. Here it tells you you may not find anything. Okay. So I ask for cuts, scrapes, there's a history of punctures, trauma of any sort. If you're doing an HPI. So how do we treat? Serious muscle spasm or seizure head. Let's give them some value. Okay, diazepam. That's going to help your patient a lot. Okay, so don't forget that aspect. We're going to treat the disease by giving them the immunoglobulin. Okay, the tetanus immunoglobulin. Remember, immunoglobulin only gives you passive immunity. What that means is that it's going to stop everything from getting worse from this point now, but everything that already happened is happening and still causing problems. Okay, what that passive immunity is going to do is going to allow your body to get together and try to fight it. Okay. And then we're going to give them some metrodiazole. Metrodiazole is the med of choice to take care of tetanus. Okay. Now, if you are not vaccinated, you need to get vaccinated. There are 3 types of vaccinations. Okay. You have, it's not on there, you have big B, big T, little A, big P. Okay, DTaP. That one is for babies. Okay, when you're a baby, that's probably what you got. Okay. Big B, big T, little A, big P. Usually for kids 7 and under. All right. Then you've got big T, little E, little A, little P. That's for kids older than 7 up to to adults. And then you have TD, which is technically your booster that you get after 10 years. Stuff usually lasts about 10 years or so. If someone gets possibly tetanus, and they come in and their tetanus shot is greater than 5 years old, we usually go ahead and give them a booster. Okay. If their vaccine is greater than 5 years old and you think they have tetanus, you just give them the booster. The booster is TD. Okay. So on the bottom it says TD. That's the booster. Okay. SIRS. All right. So this is a little bit different than everything else that we've talked about. Okay. Everything else that we've talked about here so far is all been toxin related. Bacteria goes in, causes some sort of toxin, and it makes you sick. SIRS, systemic inflammatory response syndrome, is not a diagnosis. SIRS is like fever of unknown origin. Something is causing you to have a systemic inflammatory response. What that something is, I don't know. That something can be a lot of things. Bacterial, fungal, viral, whatever. It could be a whole bunch of different things. Okay. If somebody asks me later, and there's going to be on the test, don't remind me, I'll let you know. Just kind of look at it. Because this is not a diagnosis. All right, you're going to go through this, and you're going to try to figure out what the problem is. Because once you figure out what the problem is, then you can attack the problem. When you have SIRS, it's just telling you that something's happening. Now I got to go figure out what's causing the problem. Right? Whether it be infectious or non-infectious. Okay? This is technically the body's reaction to infection caused by bacterial, viral, toxins, inflammation, trauma, or several combined incidents. Multiple things can be happening to you. Right? Your body just has an overreaction to something that's happening. Why? Don't know. Okay. Big problem with this is if you don't figure out what's causing the problem, and a lot of times it's usually either a bacterial infection or some sort of carcinoma, right? Or cancer is usually what spurs these things off, most common. This thing can lead you to organ dysfunction or sepsis, which will include hypoxia, respiratory failure, urea, renal failure, encephalopathy, coagulopathy, liver failure. It can lead you to a whole bunch of different things. Okay. So just keep in mind, this is not a diagnosis, but it is telling you that you need to figure out what's causing the problem. So here's some criteria that'll put you in the SIRS category. 2 or more of the following. Fever of more than 104. But look at this one. This one also tells you body temperature less than 96.8. We haven't had a low body temperature in anything. So this one gives you a high temp or a low temp. Okay, so it's different. Because that one's really going to be based on the problem. Heart rate more than 90 beats per minute, respiratory rate more than 20 beats per minute, or arterial carbon dioxide tension less than 32. Right? The standard for carbon dioxide should be 35 to 45, but this one's already less than 32. And then you may have some abnormal white blood cell count, right? Especially if it's a bacterial issue. Right? When you have an abnormal blood count, there it tells you greater than 12,000, less than 4. What does that mean? That means you're either making more or you're losing a bunch, depending upon when you catch the problem. Okay. The standard range is anywhere between 4,500 and 11,000 for white blood cell count. Okay. Depending upon where you go, men and women may differ a little bit, usually by 1,000 or so. So depends on what range you're looking at and what lab. So 2 or more of those can put you into systemic inflammatory category, which means you need to go do some hunting to figure out what's causing the problem. Big key for this is API. Right? just like fever of unknown origin. How do you figure that out? Big key is HPI. Where have you been? What are you doing? What have you done? Okay. What have you eaten? Have you taken any new medications? Right? That one's important because look, if you're on beta blockers or calcium channel blockers, you may not have an elevated pulse. So that one criteria might not even be effective for you, right? And just like COVID, respiratory rates the most serious marker of this thing, because that's only going to show degradation of the individual patient. Big questions to ask are, have you taken any new drugs? Right? Here it tells you beta blockers or calcium channel blockers, kind of specific. Steroid use is another big one. Right? Do they have any serious pain issues? Right? Kind of proportion. And do they have any cardiac or arrhythmias? Right? Because all those can lead you to different reasons why they may have a systemic inflammatory issue. Right? So good history can eventually get you some clues to a possible underlying comorbid condition that has not been diagnosed yet. Okay? Malignancy, immunosuppression, diabetes, big ones. Okay? They can have constitutional symptoms such as fever, chills, and night sweats. May also be an indicator for underlying conditions. Okay, those are some of your B symptoms. Telling you that, hey, maybe this person has cancer. It just has not been diagnosed yet. At this point, you need to try to formulate some differential diagnoses based on what you have, so that you can start figuring out what labs or exams or physical exams or studies I can do, so I can kind of narrow this down and attack the underlying condition. I wouldn't be extremely concerned with these, here, stage 1, 2, or 3. There's generally 5 stages. Dr. Bone laid out these stages as how things would generally progress. Here you have erythema, swelling, pain, heat, and loss of function due to inflammation of certain joints. Okay, that would be your stage 1. That's usually what happens. Most of this stuff is usually localized. Okay? It's not systemic yet. It's usually in specific areas. That's your first stage. Okay, your second stage is more of a compensatory anti-inflammatory response. Okay? It attempts to try to get your body back into immunological balance. Okay? It's got all your local cysteines released into the circulation to try to improve some of that response that happens. Right? It's trying to get you back to homeostasis. It's trying to get you back to normal for you. Okay? You'll have a little bit of malaise. You'll have some low-grade fever. You already started with some temperature in stage 1. Now you're going to low-grade fever. Now this stuff, as you can see, local cytokines, which means certain areas where you may be affected, may be causing some of the problems. Right? This is the bad stage. This is where the scales may tip over towards a pro-inflammatory reaction. Okay? When you get to stage 3, it's going to progress to the endothelial dysfunction. Right? And here it tells you the inflammation continues and homeostasis does not occur. The cysteine release leads to destruction rather than protection. Because just like we talked about with toxic shock syndrome, your body just starts blowing up everywhere. Your inflammatory reaction just in all your vessels just starts overwhelming your body. Okay. At this point, there it tells you the humoral cascade and activation of the endothelial system activates, leads to loss of circulatory integrity, causing vasodilation and increased vascular permeability. At that point, all your vessels are starting to leak out everywhere. Okay. Not good. I just need to try to figure out why that's happening. Okay, and if it continues on without supportive and aggressive therapy, and trying to figure out what the underlying cause is, this person can continue on to end organ dysfunction. And then you have stage 4, which results in a relatively immunosuppressive state, because everything is like just not working. And then stage 5 may be multiple organ dysfunction failure. Alright. So most death and serve patients are associated with malignancy. Okay. So undiagnosed cancer of some sort, most common. Okay, prognosis depends on the rapid identification and treatment of the source. The sooner you can figure out what's causing the SIRS, the sooner you can target your plan so that you can have better outcomes. Okay. Patient immune response varies, it really depends on when you catch a disease, or if that person already has comorbid conditions, or if they're immunocompromised. Okay. And then if you can swab or culture anything, the web cultures, do all that stuff you sent off to the lab. Okay. And then maybe you'll get a result, and then you can try to do some drugs and bugs so that you know exactly what kind of medication you can use. All right? Okay, got any questions? How many of you have had the measles? Nobody? Because we've been vaccinated, probably, huh? Yeah. So here's a whole bunch of things that we're going to talk about. And the first thing that we're going to talk about is measles. Okay. These are all viral. Okay. Measles are highly contagious. Mostly affecting kids, not usually adults as much. Usually what happens is you breathe in, you inhale them, okay? It gets into your epithelial cells. Once it gets into your epithelial cells, macrophages and dendritic cells get infected, and then it starts going systemic. Okay. Now, these are also known as rubiola. So make sure you guys remember the other name of what measles is. Alright? Don't start getting confused with rubella. Alright, so here are some. Okay, spread by droplet contact. Highly communicable. That means it's very infectious. Like I said, once it gets to your macrophages and dendritic cells, it becomes systemic. Okay. Incubation is usually about 7 to 14 days. And usually you'll get prodrome symptoms. And the prodrome symptoms will be fever, conjunctivitis, coryza, and cough. Okay. You guys don't remember what coryza is? Coryza is inflammation of the nasal passageways where you get stuffiness and all that other stuff in your schnoz. You're going to highlight stuff. You can highlight your prodrome symptoms, and you can highlight Copley spots. And next to Copley spots, it says pathognomonic. If something is pathognomonic, it's very specific to the disease process we're talking about, right? And in this case, it's measles. So Copley spots are just small spots on the buccal mucosa. Okay. They usually appear during the prodrome and before the onset of the rash that you get. They look like little grains or spots of little white sand inside your mouth. Okay. So you see these little white spots back here? Those are what little Copley spots look like. Okay. Little white spots based right on the back portion of your mouth. You can't see it too well here, but what you can see well is the sandpaper-like rash that happens on your body when you get the measles. This is a pretty good picture. A red blotchy rash there. Usually begins on the face. Okay. So characteristic red blotchy rash appears on day 3 to 7. Begins on the face, then the trunk, and extremities. Right? And this one, straight down. Okay, straight down. That's how it presents with your little rash. Then it becomes generalized, so it's your whole body 4 to 7 days. It lasts for 4 to 7 days. So just like some of the other ones that we talked about, this one also desquamates, so the skin peels off. Like it's a sunburn. Okay? You may have some leukopenia, may. Okay, that is not definitive. Because we really don't do labs for this stuff. We usually will do clinical diagnosis for this stuff. Okay? See that sandpaper rash? That's very distinctive. Okay? There's more sandpaper rash. This one you can tell it's really rough here. Right? Really rough. When you run your hand over it. Okay, here's another one. This one's all over this face, back. Okay. Usually here we don't see this much until lately, when we really have not been vaccinating our kids. Alright? Now, we don't have 100% immunity, even if we get vaccinated. It's not 100% immunity. There's a percentage that is immune. But, on average, we have herd immunity. You guys remember what that is? Right? Yes? No? Maybe? Okay. Most of us are covered with the vaccine. Let's say O.C. Fleming doesn't have it. She didn't get the vaccine. But everyone around her is vaccinated, right? So that's your herd immunity. It's going to protect it from getting to her. Okay? And that on average is about 2 to 5% of the people. Okay? On average, 2 to 5% are protected by herd immunity, because that may be the number that doesn't seroconvert. Right there at the bottom there, it says failure to seroconvert in immunized children, possibly 2 to 5%. The protection by herd immunity works very well. In developed countries, in underdeveloped countries where they don't have the vaccine, they're not protected. Okay. This is highly infectious enough that if you are unvaccinated and around someone who has this, 90% of the people will get it if you are unvaccinated and go around someone with it. Okay? Other considerations, vitamin A deficiency. So I would remember vitamin A associated with measles. So you can probably highlight that. Okay? Case fatality rates in underdeveloped countries estimate 10% globally. Okay? And 30% in some locations, depending upon where you're at. The CDC estimates that about 134,000 people die globally because of measles. Right? It's not necessarily the measles, but some of the complications that it causes, like pneumonia and encephalitis, that usually end up killing people. Okay. Complications, hepatitis media, pneumonia, croup, okay. And disease, obviously, more severe in infants and older people. One of the big things that really most folks don't really understand with the measles is that once it becomes systemic, and it starts attacking your body, it kills your B and T memory cells. If you guys remember what those guys do, those are your long-term cells that keep the information of you being sick for other reasons in your body, so that when you do get sick or you do come into contact with that other virus or bacterial issue, you already have some in your body that'll go ahead and help protect you. Okay? This causes memory immune amnesia, is what they call it, because they've killed so many B and T cells, memory cells, that you're prone to getting sick to something that you would normally not get sick to anymore. So it usually takes a couple of weeks to months for your body to start developing those memory B and T cells again, so that it starts protecting you. So keep that in mind. That's one of those bigger things that we don't usually think about when we think about measles and recovery. There's your death rate. Usually less than 5-year-olds, primarily because of pneumonia encephalitis. Okay. Remember, the malnourished folks are the ones that are most prone. Here's a rash that's desquamating. Okay, diagnosis is usually made clinically, we don't usually send off for stuff. And you can do IgG, right, but usually we don't. Usually they can spread it just before the prodromal period and 4 days after appearance of the rash. And there's a whole bunch of folks that have be susceptible, particularly folks that are not immunized. Prevention is really key. Immunization. Fluorescent immunoglobulin, but usually we don't really concern ourselves too much with that. We do have a vaccine for this, usually get it when you're younger. Okay. Remember, vitamin A is associated with measles. And this is where we're stopping today.